I'm going to open the subcommittee session on Senate Bill 397 in reference to the Mental Health Counseling Compact. That will be the only part that we'll be working on. The amendment to this bill is going to be done in a separate subcommittee hearing, as it is a kind of a different topic here. So just as a reminder to everyone, this is relative to the Mental Health Counseling Compact. And we did have a public hearing on this already. We did entertain several questions in reference to the processing of this and how it works. In my notes, this would, to freshen everybody back up, this would require 10 states in order for this compact to take effect. Maine, Maryland, Alabama, Louisiana, and Colorado have already enacted this. There are 15 other states considering this compact as well. The only other New England state is Maine. We had a standard series of questions in reference to discipline, as to which, if someone commits an act or there's a problem, how is that handled? We went over that as to who gets primary jurisdiction there. We were informed the U.S. Department of Defense is on board, and the Board of Mental Health as well. So I today have Representative Woods with us from Health and Human Services, who is quite familiar with health compacts. So I asked him to be on this subcommittee, as this is a bill that involves Health and Human Services, really. So with that, I will entertain any concerns or questions anybody has in reference to this.
Mr. Chairman, I would just like to say that as the Vice Chairman of the Telehealth Commission, we've discussed this at the Telehealth Commission as well, and it would certainly make our life a lot easier in resolving interstate issues if the compact were adopted.
Excellent. Thank you. And the other question that was brought up, that I brought up, that we seem to have a little bit difficulty in getting processed was, you know, this is a transitional piece of legislation, as we are going to be leaving a compact and entering into a different compact. And in reference to the processing of that, and for those of you that are familiar with, well, computer programming, some other things, this is kind of an if-then scenario, whereas we are not going to put ourselves or the state of New Hampshire in limbo, exiting a compact without entering into a reformed or new compact. That's not going to cause New Hampshire to become an island, in the sense that we've now just isolated ourselves. So we didn't, looking through my notes, we didn't really seem to hear anything in the way of objections. I don't recall any testimony to the contrary that was heavy. So Representative Allegro.
In general, I'm in favor of compacts like this that make licensing issues easier and provide services easier. I have a problem and a serious objection, though, to this particular compact. The problem is there's a difference between interstate compacts. Well, let me put it this way. Figuratively speaking, you can't talk somebody down off a building on the phone.
Sure.
So there's a lot of things that you can do, but I'm not sure this is one of them. I've like education, I am a firm believer that face-to-face is very important for this particular practice. But then there's something in here that's a red flag to me, that if it stays, I cannot and will not support this bill. And that is, if you look at the bottom of page 2, under Roman numeral 1, to participate in the compact, the state must currently, the first few things make sense: license and regulate licensed professional counselors, require licenses to pass nationally recognized blah, 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 require licenses, so on and so forth, orientation and ethical practice. And then we get to number 2. Well, under C, it's requiring licensees to have a 60 semester hour, 90 quarter hour master's degree, and so on and so
All
forth.
right, so help me out here, because I don't see that on my, you're looking at, you'll need the printed
He's on
copy
page 4.
to give page and line. Okay.
Okay, thank you. On this, it's saying page 2, but it's,
Oh, I see. Okay, so
You
on
got it?
page 4, line 2, part C, the requirement for 60 semester hour and 90.
right.
Okay.
And the first few make perfect sense to me, or most of them make perfect sense to me. Then you get to training in social and cultural diversity.
Mhm.
I will not accept this premise any longer. I cannot and will not support any bill that has this type of terminology in it. And it's a poison pill, really, because then further down it makes a very, under other circumstances, very reasonable requirement under number 9 in parentheses. It says other areas is determined by the commission, and that would be fine. It's understandable that they need the flexibility to add or take out training requirements, except that I know it's not misinformation or disinformation or conspiracy theorism. I know that leaves the way wide open for somebody to say, okay, we'll take out social and cultural diversity and we'll leave in number 9. And that means social and cultural diversity goes back in under another name. I've had it with social and cultural diversity proclamations. Cannot and will not support it. Sorry about that. I really am.
Okay, so one of the things that is, I think, relevant in this world is the fact that folks that have a different background handle and approach social work differently. And I think that element of that is something that is well integrated into the profession already. You know, and I don't look at this as that. I don't look at this in the sense of them trying to manipulate that. I think it's just a matter of there are some cultures that just handle this type of thing differently. And, you know, that's something that's going to exist in all aspects of this. I would imagine it probably does in the current compact. So that, I mean, if that is the ultimate poison pill for you to agree to enter into this compact, then I think that there's almost no way around that in the mental health profession at all, because the state of New Hampshire can't pull that out to enter into the compact. It's a go or no go scenario. This is the details of that compact, but it's a matter of, do we accept the conditions set forth in the compact for the state of New Hampshire or not as a mass. So Representative Woods, jump in with there, certainly as someone who's extraordinarily familiar with these.
Well, I completely understand and appreciate the difficulty which you mentioned. However, this is I'm for those of you who don't know, both of us are physicians, and was New Hampshire's delegate to the AMA and listened to and served on Council on Science and Public Health. But part of that debate was cultural diversity awareness for the physician. That's embedded in our code of ethics, which is how physicians are judged. I'm not talking about the other ancillary nurses and so forth, but embedded in there is awareness of cultural diversity, and that's embedded in an RSA that we have to follow the American Code of Ethics. And by that is meant awareness of sometimes simple things like being aware of getting an appointment and realizing that may be a major holiday for an individual that, say, Muslim, and it's Ramadan. Or being aware that under some circumstances that a teenage girl, even though she may be 16 or 17, can't have an appointment under some circumstances, even for, I was a hand surgeon, checking out a hand problem without her father being there and being aware of that. So that is, I appreciate what you're saying, but I think, again, I'm reading how they meant this, but that's the kind of thing that we as physicians, and I think that would apply here, that's meant to be aware of that so you can better communicate with that particular individual on a one-to-one and a personal basis. But just to reiterate, again, the way the compacts work is you can't change them. It's all or none. But having said that, and I don't, part of this was not the enabling piece that goes with this. And by what I mean by that, there is an enabling, I don't know what you want to call it, a piece of legislation, shall we say, that the compact organizers put out. And in it, it states soon as X number of people, in this case 10, that it goes into effect. Now the first, I've forgotten, usually it's 5 or 6 or whatever. Once that has been formulated, then rules can be promulgated. And the first 5, 6, or 7 are at the table and then can look at rules and make those changes. So if you're, say, they say the first 7 that join will be part of this review committee, and that then takes place. And some small issues can be addressed, and they need to be addressed. An example is, if you look at page, and this I see stuck over from when we considered it, I've forgotten when it was, 2 years ago? At least on the 397 as amended on page 2, line 37, it says home state means the member state that is a licensee's primary state of residence. Well, that should be the primary state of practice. Because, and again, the example is, I live in Vermont, but I just cross the river and I practice at Dartmouth Hitchcock.
Sure.
So what you want is, so this really creates a bit of, and it was pointed out back, I forgot when that was now, but that line is still in there. So those are the kinds of things that this rules committee has the ability to address if you're the first. And again, I've not been privy to the enabling piece that goes along parallel with this. And you may have that, which I don't. So there's a number of factors. Since I'm talking, the concept of compact is part of a national effort to make uniform standards. And this is evolution in terms of standards. My great-grandfather was a self-taught horseback doctor out in the plains of Texas. He didn't have to have a board of medicine, anything. He just, I'm here, I'm the doc, and we've progressed along. And this came through such that finally we come for specialty training for physicians. We have the American Board of Medical Specialties, such that there's 26 specialties that are recognized. And that avoids a lot of, quote, certifying agencies. Like when I chaired the Workers' Comp Advisory Council, we looked at people who could do IME, or independent medical evaluations. Well, it turns out if you were certified to do that, you could do them. Well, it turns out there's 400, at that time there was 450 or so certifying agencies, 130 of them in Las Vegas. So that tells you a little bit what they were certifying. So I got a piece of legislation passed. I wasn't in the legislature at the time, but as a chair of the Workers' Comp Council, to say that in fact, to do this particular IME, or independent medical evaluation, you had to be board certified by one of the 26 American Board of Medical Specialties. And that gives you a national standard because these are national tests. I did orthopedics, and everybody in their specialty passes boards. And that gives a standard, okay? Looking at that particular issue, I was ultimately sued, as a matter of fact, because someone who was doing IMEs wasn't board certified, and the AG's office got involved, and they said, we'll take care of it. So I got off the hook. But there's been this ongoing from my great-grandfather doing it on his own, American Board of Medical Specialties, to provide national licensure, so a national standard to make it so that as a physician, I can move from state to state. As a patient, you can continue your care on a standard basis. And I think that's critically important. And the FSMB, or the Federation of State Medical Boards, has been advocating for national licenses. This is an example of a type of national licensing for as long as I've been associated with them, for 30 some odd years. So I view this as a progression from my great-grandfather through all the certifying agencies in Las Vegas to a national standard to enhance patient care. And in fact, I was up until recently also on the Telemedicine Commission, and we heard testimony where, in fact, one of the biggest uses was mental health. And it made a huge, I mean, we're talking big time impact. And the follow-up data shows that it was efficacious in that particular setting. And in fact, there was a significant, I've forgotten the numbers, but significant numbers that preferred being able just to call rather than having to come in. Not that they didn't, I think it's that progression of our use of technology. It'll finally sort itself out how it's used, just like a new drug. As soon as the drug hits the market, boy, its use goes off the charts. Then it drops down to people, and then it stabilizes. And we're doing the same thing with telehealth. It's a technology that is just asking to be used. And I often say that medicine's often on the dull edge of technology. But in this situation, medicine is really responding and making good use of it. So I'll stop, sorry, going on, but that's a few extra comments on sidebars as well.
To piggyback a little bit, I sit on the PTSD Commission, and there are people that specialize in that type of thing. And in New Hampshire, I think we have, for first responders, we have like 2 for the entire state. And that the commission found out in a hurry that without reaching out across New Hampshire's borders, we got a problem. And this is certainly an area where people specialize in some cases. The military has folks that have specialized for years in that's really more military related. But there are certain aspects of mental health where there are folks that focus on certain aspects. In New Hampshire, as we all know, is a relatively tiny state. So in those cases, folks may, what is most cost effective and most productive for them as far as treatment may really rely or require them to branch out into some other locations. And I think that's what ultimately the current compact is attempting to do, and certainly this one will do as well. So that's just an example of how we can't necessarily handle this in-house. Representative Marsh.
Yes, thank you, Mr. Chair. I just wanted to add a couple things to what Representative Woods just said. First of all, I just checked the website of the Mental Health Counseling Compact. It goes into effect when 10 states have adopted it. And according to their website, right now, 9 states have adopted. So if New Hampshire adopts this, it goes into effect. We don't need to worry about contingencies. The second thing regards to the efficacy of telehealth in addressing various behavioral health issues, and in fact, to do counseling. We've heard a substantial amount of data, which is being collected by the federal government to that effect. At the Telehealth Commission, they have postponed making a final decision about parity and audio only because they're still collecting data, and I recognize that. But one of the things that has come out in the commission is that telehealth in this circumstance is extraordinarily effective, and in many ways more effective than in-office visits, because the practitioner, through the medium of telehealth, is brought into the home of the person being counseled. They can see what conditions they live in. They can see what other issues that they're dealing with, and they also have a essentially 100% show rate, so you don't have people not showing up for appointments, and that has made the service hugely more effective, and it's made this actually a preferred modality for people practicing this kind of medicine. So I think that we need to recognize that that's what the actual data is showing.
So along with that too, the other thing is, from a licensing standpoint, right? We've, in this committee for quite a while, have tried to figure out ways to remove barriers, and in a lot of the cases of licensing, and we've had discussions in here about, reciprocation versus recognition versus compacts, versus, because those are all obviously different avenues as far as, is my license that I have in Vermont recognized? Is it an equivalent? Do I have to get a different one? And, we've gone back and forth on several bills this term in reference to that, from everything from mental health to hairdressers, frankly. So, this is one of the things that I think is appealing, in the sense that it doesn't require the state of New Hampshire to open up. This would probably not fall under, well, OPLC is okay with it, so I guess maybe this would be going to them, but they're not going to have to add staff. They're not going to, you know what I'm saying? Because we're in a compact now, it's just recognized. You see what I'm saying? So that's just I know this is this thing's 20, 30 something pages long, and the reality of it is it's the details of what's being presented before us, in the sense of, it's more advisory. I mean, we can't, like I said, we can't amend this. We can't pick it apart. We're either doing it or we're not. And I think that it's not perfect. There's no doubt. I mean, but at least, I mean, you have, so a lot of these compacts have incentives to get in early, right? Because you have rulemaking councils and things like that. If you get in the door early, you get your seat at the table is a little bit bigger. And, it's interesting that, things are moving along. When we had the public hearing, there were only 5 states that had enacted. I mean, we're at 9. So clearly other legislative bodies are going through their motions of processing this. And, this sounds like it's going to happen. So this thing's going to exist. One of the questions that was not asked, and I didn't think of it really till now, is the now 9 states that are just waiting on a 10th state, I would presume, are going to exit whatever existing compacts they have to get into this. Now, we don't have representatives from other states here to answer that, but the current compact that we're in, what happens if half the states that are in the current compact now leave to join this one? The compact that we don't. The compact that we're now involved in is now smaller, less effective, and probably chaotic in the sense that you've got members of, it could be members of the rulemaking part or the upper part of the administration of that have exited. So I didn't think to ask that at the time.
Generally, when a state leaves one compact and joins another, they would do the same thing that we're doing in the second half of this bill, where when the contingency is met, it's a repeal and replace, and it replaces.
No, I get that, but what I'm saying is that because we're in a current compact, so if we're in a compact that's currently with 15 states, and 9 of those states leave the compact and enter this new one, now we're in a compact. We're not in a compact with 15 states anymore. We're in a compact with 6. And now you're talking about the efficiency of the compact that you have.
Yeah, I'm not sure that we're in a mental health counseling compact at this point in time, because this bill is written to make this a new chapter, as opposed to repeal and replace.
Okay, because am I confusing this then with a different?
Yes, the second half of this is a compact, which is a repeal and replace.
That's what it is. All right. So that's the part we're not talking about today. Gotcha. All right. You see my point, though not applicable here. We'll deal with that Monday, but, so yeah, so I guess we have nothing. That's right. If we have nothing on the mental health side, then,
Which is why we have such a shortage of mental health professionals in the state of New Hampshire.
and like I said, the PTSD Commission was specifically addressing that, in reference to that field, the first responder field, and what the PTSD bill that came out really doesn't address that because it's waiting on this. So the PTSD Commission is waiting to figure out what we do with this, because like now, at least in their world, this opens it up to 10 states and potentially someone that could now decide to specialize, because now they're gonna have a client base that's large enough to do so. So
One of the issues we have in the North Country is that the counselors who provide this kind of service don't choose to live in that kind of environment. So prior to the advent of telehealth, most of these services were basically unavailable up where I live. And the availability of these services through telehealth has hugely increased the availability of this kind of service to my constituents.
Just to feed on that as well. One of the reasons it's really been so well utilized, let's say that your mother dies in San Antonio, and you go down there and there's all kinds of issues and you're beginning to fall apart. You can now call across state lines.
sure.
Also, if you're in the North Country and you're trying to get a job and it takes 2 hours to get to the office, your employer really doesn't like you taking the day off once a week or once every two, or whatever it happens to be. You can do it on your lunch hour.
Sure.
So you get much higher participation, much lower dropout. Employers really like it because their employees are healthier, and also letting them even take an hour off in the middle of the afternoon, shall we say. They can do that easily in the most instances, and that gives a nice expression of concern to the patient as well. That, yeah, I'm the employer, but yeah, go ahead, take an hour, and they don't have to take the day off. So there's many other watersheds that come when this is put in play.
So I guess the other thing that I'm just thinking in reference, Mark, to your concerns is that realistically, as you're aware with most compacts, they're fluid, right? So they're fluid in the sense that there are compacts that the state of New Hampshire has entered into that when these boards meet, can make changes and modifications. And really, I mean, New Hampshire has a seat at the table, and we can object and or support whatever's going on. And then ultimately, if a compact becomes such that the state of New Hampshire finds it unacceptable, our option is to leave. I mean, that's really what exists. So,
And again, I'm referring again. You mentioned it, changing things, and again, it's not here, and you may have them, but the promulgating documents, and those are the rules by which things can be changed. Yep. And the committee, when the full committee wants to make it, they may want to know, well, how, what are we restricted in if we do join? What kind of restrictions are there placed? And they may want to have those promulgating papers in hand. I didn't actually look for them from our previous, because we had them available. And there maybe some questions arise as how how can things be modified and how hard or easy it is.
and we've done that. I mean, we did it last year, that we pulled out of an interstate compact because it just wasn't functioning for us at all. So the state, the legislature has done it, and they will do it if it's necessary. We've clearly shown that. So,
The amendment terms are on page 18, lines 31 to 33. The compact may be amended by the member states, and no amendment becomes effective until it's ratified into the laws of all the member states. So the provision is there on how to do it.
That's for the second.
That's the first one. The second one starts on page 19.
So I think that that's kind of just where we're at here. Do we think that the state of New Hampshire will benefit from entering into a mental health compact or not? And that's, and we didn't really, other than that issue, there really hasn't been anybody that's come forward with other objections. Yep, Representative.
Yes, so let me step back a moment and see what else can be done if there are issues with the compact itself, because I'm reading through testimony of the director of the OPLC, and there was an emergency license for 2020 and 21
Yep.
that was issued.
Right.
Can we work that angle instead and
So
extend those licenses?
So what you're, if I'm understanding what you're asking me, instead of entering into a compact, we have our own basically reciprocating agreements with.
Well, the emergency order allowed the OPLC to issue
Sure,
the licenses.
but as
And here,
you and I have discussed well, actually, a lot of us have discussed our displeasure with using emergency orders to operate anything.
Exactly.
So at that point, I mean, if you want to set this up in a functional way that is not under that premise, then you're talking about either getting into a compact or opening the state up with inventing our own, in essence. Because if we were to do reciprocating license agreements with other states, we're inventing another wheel that we already have.
Unfortunately, the state of Massachusetts is not a participant in the compact at this time, and the vast majority of the emergency licenses went to the practitioners in the state of Massachusetts. So we haven't solved that problem yet. The legislature in the state of Massachusetts could solve it by adopting this compact as well as several other compacts, which the state of New Hampshire is a part of.
Now, the other thing that I didn't see in here, and correct me if I'm wrong, but this doesn't prohibit us from doing that. If we wanted to enter into a reciprocating if Massachusetts rejected this in its entirety and said just we're not doing it, we wouldn't be prohibited from entering into a reciprocating agreement with the state of Massachusetts. We would not. There's nothing in here that says we can't play with other people in the sandbox once we enter this one. So
I'm not sure there was something we were reciprocating. I believe the OPLC issued licenses to those who were licensed in other states, no matter what their home state was doing to us.
but by entering into the compact, right, that
I don't see that in the testimony. No compact is being discussed here. Lindsay Courtney's testimony.
well, the OPL, in specific reference to 397, in my notes, I have that OPLC was on board with this.
With this bill, yes.
Yes.
I'm,
So,
I'm talking of a different way, which is what they did during the last 2 years.
right. But yeah, and we're going to have, I
Outside of
think we're going to be
compact.
duking it out over that on Monday when we exec it, as far as,
So you're talking about making that the model rather than.
Yeah, so we're in charge.
I could see that very easily.
Because it worked so well in 2021
Mhm.
and so brought in so many psychologists and family therapists and mental health counselors, and there are the numbers here
Sure.
in the testimony. Yeah. So
Well,
some kind of an approach like that.
it would be interesting to hear the opinions of the OPLC director in reference to the state of New Hampshire creating, in essence, its own compact versus getting involved in an existing one. I think that's, if you don't want to grow government, creating your own compact is going to require that you just don't throw that down on paper. You're talking about, you're going to have people to manage that. You're going to have that's
We can ask them what they did for the last 2 years. So
Yeah.
they were quite successful, it seems like.
well, and maybe, yeah, we would have to ask her if she agrees that she was quite successful. Do you have anything to represent?
I just want to say it. I recall hearing during testimony that the statement was made that basically Massachusetts does not join compacts. And they are obviously the, how shall I say, money state of northern New England. I think they feel like they can call their own shots. I'm not sure that New Hampshire has that much.
Yeah, I'll
say.
point out that they did introduce the physician licensing compact in March, so that may change.
Yeah, and I mean, it's not a big secret, right? Folks in New Hampshire that need to see some higher level medical care and specialty work go to Boston. It's not a secret. Boston is a substantial worldwide hub for medicine, and we discussed that in the other hearing about cross border. I mean, my stepmother's a physician on a border town in New Hampshire. She has privileges in both states because a lot of her folks in her practice go to the Hale in hospital in Haverhill. So, I mean, there are some things in place right now, but that's more, she's a physician. She's not a mental health practitioner.
Yeah, just addressing the issue, I think if a OPLC was able to really have a good program and be very nimble and responsive is one thing, but I think the hearings, as you may recall, that was one of the real hangups. They can't be unless you have 10 more FTEs, and the reason we can't get people to participate across borders and get a secondary license is it takes forever
Right.
To do that, and as a consequence we lose that nimbleness, especially when and also reimbursement issues come into play too, for sure. That's another issue, but
So I think as a committee, we're obviously going to, when we get into executive session, we're going to be duking it out over both concepts. And I think that, at least in my mind, having OPLC in the state of New Hampshire start getting into the compact creation business is beyond the intention, I think, of what we were trying to do. We were trying to shrink government by creating the OPLC.
I don't see it as a compact model. I think Michael is proposing just licensing people from out of state. What's more nimble than that? You got a license in your state, you can practice in our state.
Yeah, I mean, if you're talking about full reciprocation,
Exactly what they did in the last 2 years.
Yeah.
For the last 2 years.
Yeah,
okay.
just making it permanent.
No, I think that's a discussion that we'll have to have with the full committee, certainly. And that would, I think that's going to require we invite the OPLC back here to talk to them about what that would realistically look like. Because I don't know exactly what that would realistically look like, but they would be the ones, that's the agency that would manage it if it existed. So,
And they've already done so.
you
Yeah,
know,
they would know exactly what we're talking
they would
about.
know exactly. So
Yeah.
that, I mean,
That's
certainly a legitimate policy discussion in reference to this. So, but other than that, I think that that's just kind of where we are with this type of bill. We're not, unlike other bills, we're not getting into page 15 and trying to strike out a line or anything. This is just the recipe for the brownies that we're either going to eat or not eat, and I guess we'll duke it out. So, as far as the technical aspects of a subcommittee, I mean, subcommittees technically can make recommendations. I would think that the recommendation at this point would be to discuss the two options, the two models at the full committee, and not necessarily decide whether the subcommittee is going to vote yes or no on this particular piece of legislation, because I think that if we're gonna come up with two concepts, then we need to discuss them both at that time, because otherwise we're going to continue to remain an island, and I think that's a problem. We can't continue to remain an island.
Agreed. I'd just like to say, I'm really sorry that I'm being a stick in the mud on this. But here's the truth of the matter. Everybody in this room knows that no rules committee is going to modify that item. It's a political pill that's embedded in there. And no rules committee is going to change that. A rules committee rightfully and hopefully will change rules that actually make the compact work better technically and medically. So if this were an issue of a technical issue, a medical issue, wouldn't even have arisen in my mind because I know it can be fixed. I still remain unconvinced about the relative value of telemedicine for psychological counseling. I too have a little bit of experience in medical research, interpreting it, reviewing it, analyzing it, and I'm underwhelmed by what I've seen over the past 35 years. And I'm also quite cognizant that if you ask a podiatrist if everybody should see a podiatrist every 48 hours, well, they'd say yes. Okay, and there's research to support it. So, with all due respect, I'm not convinced that telemedicine for this kind of thing is the best choice. And number two, I just know that this political pill will not be corrected. And thanks to Rep. Yakubovich here, he's given us another, I think, very good model to consider. So we can still fix the problem. And I'll leave it at that, and I'll be happy to hear any other, comments to address my concerns.
Oh, I think I tried to understand your point of view, but I think it's as just to reiterate, I think it's there such that as the AMA wants physicians to be aware of cultural differences, and I think that is crucially important, and I think it was meant with that intent. Again, maybe I'm giving credit where credit is due, perhaps. I'm not sure. I wasn't there at the promulgation of it, but I would say that erring on the side of that the intent was not a political statement by having that included. And I think it was included, and it would be included in anything that, as a physician, I would actually expect it to be included. And if it were not, I would be very surprised and dismayed if it were not included, because as our society becomes more diverse, we need to be responsive and appreciative of those differences. And if we can do that, it gives us better understanding for people that have a different background and sometimes those backgrounds have created part of the problem that brings them to our attention. And that's part of that understanding. So in that sense, again, I will admit there could be wrong, but I don't think the intent at all was political. I can see where if one were to choose could make that interpretation. But my interpretation, again, comes from having served with the AMA and knowing what we're required to do and the understanding we're supposed to bring to the table when we see a patient and understand that patient in all their dimensions.
Thank you. Thank you guys for coming here. Gorgeous day. Last place any of us want to be. Believe me, okay. I think that's unless somebody really wants to do some sort of a formal recommendation, I think that the reality here is that we kind of have two models on how to handle this, and I think that we're just going to have to discuss that as a full committee as to what we're not choosing between two pieces of legislation. Let's not forget that, right? We don't have an alternative piece of legislation, whether we're going internal or compact. So let's just understand that. We'll just, if 397 is rejected by this committee, then let's just make sure that the reasoning for that is well spelled out. So
Can it be handled in an amendment to replace
in theory,
the bulk of this?
you could do that. You're talking.
It's germane.
It would be germane because you're talking about just a structural difference between the topic is still the same. So I can see that being germane. But typically the folks that are going to want to weigh in on this, the folks that have to actually deliver that, are going to want more time I mean, we're not really thrilled about the deadlines the Senate's given us on some of these pieces of legislation. To have the director of OPLC come in here and give a go no go on an amendment that modifies that office without a bit of a deep dive is not going to probably be well received. But it, you know, it would be something for the fall, you know. But all right. So with that being said, if everybody else is ready to go get their tan on, then we'll head back to the beach. So thank you for coming. Thank everybody at home for watching the exciting deliberations that have come on before you. So Godspeed. So don't forget to sign in, please.